The expert panel of allergic rhinitis of the European Academy of Allergy and Clinical Immunology warmly welcomes you to this first instructional webinar on allergic rhinitis. We sincerely hope you will appreciate this first and novel tool for sharing education and information on allergic rhinitis. We should think of allergic rhinitis as the cause of nasal symptoms in those patients that suffer from nasal obstruction, rhinorrhea, sneezing, and/or itchy nose. These symptoms may occur in sensitized patients after encounter or inhalation of the allergens to which they are sensitized. The inflammation is not always limited to the nasal mucosa and may extend into the conjunctiva, giving rise to itchy eyes, reddening of the eyes, and tearing, and may also extend to the lower airways, giving rise to asthma. We know that allergic rhinitis is a risk factor for the development of asthma, and therefore we should treat and diagnose our patients carefully in order to optimize the approach of our patients with allergic rhinitis. When it comes to the symptoms and the diagnosis, it's very important to recognize the fact that different phenotypes of allergic rhinitis may occur. Some patients have more the profile of sneezers and runners, whereas the other group of patients mainly have nasal obstruction as primary presenting symptom. And finally, it is important to recognize the fact that allergic rhinitis may be part of the pathophysiology and the clinical spectrum of all inflammatory conditions that we see in the upper airways. And therefore, we need to take into account allergic rhinitis as part of the pathophysiology of chronic sinus disease, otitis media, and other chronic inflammatory conditions of the upper airways.
Well, diagnosis is very important in any disease. Trying to manage a disease without a proper diagnosis is like shooting in the dark. But specifically for allergic diseases and allergic rhinitis, diagnosis has a couple of important challenges. The first challenge is to identify the phenotypes and endotypes. These are some Greek terms which basically mean that the disease is not the same and there are different subtypes within this whole rhinitis area. Each of these types responds differently to management. So the doctor has the challenge to identify which of these types the patient has in order to give them the right treatment. A very good example of that is allergic rhinitis and neurogenic rhinitis. They need a different type of treatment. The second challenge, and this is particular for allergic rhinitis, is to be able to identify which is the specific trigger. Again, the doctor has to go into the procedure to differentiate the different triggers that are specific for the patient from the ones that are not particular to them. Because after that, there is a possibility of treating the patient with specific allergen-specific immunotherapy, and this will not work unless the diagnosis is correct. So in all, we can say that there are two major challenges in dealing with allergic rhinitis and rhinitis in general. First one has to identify the group of disease, the phenotype or endotype, and then the specific trigger. We have very recently published a document called Practal in collaboration with the American Academy of Allergy, Asthma and Immunology, where we describe in detail which are these phenotypes and endotypes of rhinitis and how we can deal with each one of them.
Let me start by saying that the only way to properly diagnose allergic rhinitis is by taking a proper clinical history. Both in vivo and in vitro testing are just supportive data for a clinical history by providing evidence of absence or presence of specific IgE. In vivo testing is skin testing, and skin testing has a main advantage over in vitro testing in that it has an immediate result during the visit to the clinician. The patient has the result within 15 minutes. It is a clear result in the sense that the patient can feel the result. There is swelling, there's redness, and there is an itchy feeling if the test is positive. A problem with skin testing is that the availability is under pressure because of regulatory constraints. The reagents have to be registered, and for the companies that produce these reagents, it is problematic to afford that. It's very expensive to do clinical studies. This is not a problem for in vitro testing. In vitro testing hasn't got registration and can be provided always. The main disadvantage of in vitro testing is that the result is not immediate. The result takes a couple of days, even 2 weeks in some cases. So this is not immediate during the visit to the clinician. An advantage of in vitro testing is that it is more accurate quantitatively. We cannot say that either in vitro testing or in vivo testing is better. This actually depends on local differences in different countries and also on the preference of the clinician. Some clinicians prefer skin testing, others in vitro testing. And it depends on the place of the specialty and the regulation of reimbursements. So both tests are good and can be used, but it depends on local conditions which one is chosen.
Allergic rhinitis is a very frequent disease affecting 1 in 4 individuals. This is why it appears impossible that all cases are seen by a specialist, so in a cost-effective way, it is better to use a scale-up approach involving the pharmacists and the primary care physicians for the diagnosis and treatment of milder cases. However, some cases need to be referred, and these cases include persistent or severe symptoms affecting patients' quality of life, symptoms who do not respond to treatment after 2 or 4 weeks, symptoms who are not suggestive of an allergic rhinitis, such as unilateral nasal obstruction or nasal bleeding, and symptoms suggestive of an infection, such as fever, sore throat, or mucopurulent discharge. Children under 12 need also to be referred because of the diagnosis, which is difficult in some cases, and because the treatment has to be the safest possible without adverse events or without off-label use. Pregnant or breastfeeding ladies also need to be referred because of the safety of medication that it has to be used during this period of life. The pharmacists and the primary care physicians are at the forefront of the community and are very well trained to recognize and to put the diagnosis of allergic rhinitis and to initiate treatment in milder cases. They need to be taught how to refer patients, and this is how the educational webinar, which is produced by the European Academy of Allergy and Clinical Immunology, is trying to help them to improve the care for allergic rhinitis.
The treatment of allergic rhinitis follow rules, guidelines as we call them. And the most famous guideline is the so-called ARIA guidelines, which stands for allergic rhinitis and its impact on asthma. Most of the time, once the diagnosis is set, when we know which allergens are involved, avoidance when possible is the first-line treatment. Then, in order to treat the symptoms, you can choose antihistamines, local steroids, and some other drugs that would help the patient. Some patients really respond very quickly to those pharmacotherapy treatments. Some others resist, and when this happens, we have to go back to the diagnosis, be sure that it is allergic rhinitis, nothing else or nothing on top, like a comorbidity. Treat that comorbidity if it exists. And maybe think about some other things like allergen immunotherapy, which will be a symptomatic treatment plus a prevention treatment. but also in some cases surgery of the nasal obstruction.
Allergic rhinitis impacts severely the quality of life of children, both the very little ones and the older ones. In children below 2 years of age, we can have difficulty in breathing, difficulty in sleeping, snoring, postnasal drainage, which impact also the quality of life of the family. The trigger in children so young is usually an indoor allergen such as dust mite and pet dander. In children around 5-7 years old, the trigger is usually an outdoor allergen such as grass pollen, birch pollen. And the main characteristic is the fact that the diagnosis is usually delayed and proper treatment is delayed as well. There is the bad performances that these children present at school and the nervousness that they have usually, the itching, continuing itching, even prompt to referral to the psychologist instead to the allergist. Starting a proper treatment with local nasal steroids, antihistamine, and immunotherapy that can be used even in young children dramatically changes the quality of life of these children and of their parents.
Treatment of allergic rhinitis aims at the reduction of inflammation that is associated with allergic rhinitis. The reduction of inflammation will lead to a reduction of symptoms of the allergic rhinitis, as well as an improvement of the quality of life of the patients affected by allergic rhinitis. Nowadays, we tend to incorporate the concept of control into the treatment goals of allergic rhinitis. The concept of control of allergic rhinitis is novel and is actually dealing with the subjective perception of the patients of the degree of symptom reduction. We know from studies that with current medical treatment options, we can achieve a significant degree of control in the majority of our patients, giving them a good degree of satisfaction with the current medical treatment options that we have for allergic rhinitis. The treatment arms consist mainly of either medical therapy as well as immunotherapy. Both are associated with a good degree of control in the majority of patients and are recommended for our patients with allergic rhinitis.
Allergic rhinitis is a very frequent disease, as you might have heard, and this calls for action in a very structured plan, in a teamwork which involves specialists, the primary care physician, pharmacists, and the patients themselves who need to be empowered to take care of this disease. We encourage also the people to have a look at the resources that we have on the Academy website, which is the EAACI.org, and on the campaign webpage, which is bewareofallergy.com. The EAACI created this educational webinar with the intent to help pharmacists, primary care physicians, and patients to recognize and manage better allergic rhinitis. And we are also developed an allergy awareness campaign, which is developed throughout Europe in order to increase awareness of this frequent disease.